Welcome, everyone. My name is Rod Jacinto. I'm very happy to be here with you today. And Titanium Medical has a great pleasure to receive Dr. Fernando Duarte from Portugal. So I am very happy as well to learn from him. And Dr. Fernando, please introduce yourself. And we are excited to have you here. Welcome.
Thank you very much, Rod, and thank you to Titania Medical for the invitation. It's for me a pleasure to be here and to share in this afternoon with my colleagues from the UK my experience, not only in the treatment options in Atrophic Jaws, but also with this new implant that allow us to do immediate loading in more cases than before. And I'm based in Portugal. Uh, Sorry, I don't know why, but my slides are not running. Okay. I think I should stop sharing and I will start to try again. I don't know why, but these things always happening. No, it's working now properly. Sorry about this. I done my dental degree in Portugal. After that, I worked and studied in London at the Eastman Dental Institute at the UCL, where I done my post-graduation studies and also my first MSc in oral maxillofacial surgery. After that, I returned to Portugal, and my will to study continuously took me to Rome, where I done my second Master of Science at the University Catholic of Rome, and I done my first PhD also in Salamanca, Spain. Um, I'm based in Portugal. I give lectures around the world, and I split my time in operating, in research, what I like also a lot, and also to share my knowledge with my colleagues and to learn from them also. This topic for today is very interesting because it's not only in Europe, but all over the world. The number of implants that are placing is massive. And the problem is, I always say to my students, there's only one principle in implantology. We must place the implants where it's bone. And sometimes it's difficult to find the bone, and we try hard and hard, and we have CBCTs, and we have a lot of imageology to help us, but the problem is to find the bone. And we know there is a bone resorption pattern around the world in all the patients, and in general, this shape changes follow a predictable pattern. And when we look to the mandible, we know that mental area, symphysis and parasymphysis area is the last area to resorb, but we know that the posterior area of the mandible is sometimes very challenging with the mental nerve very near the superficial bone, what means that we should or we sometimes we have to tilt our implants for the posterior mandible, and in the maxilla also the posterior maxilla, and we need to use some surgical techniques like the maxillary sinus approach with bone grafts, also the zygomatic implants, and even the anterior maxilla is also difficult because we need to put our implants a little bit more palatine than normal. My presentation is a bit different. We just have a small introduction, and after that we go to the clinical cases. But I think it's more interactive with the audience. And we know that we lose bone by several reasons, like the removal prosthesis, the periodontal disease, multiple caries, multiple abscences, the fixed failed rehabilitation, and we know that nothing goes forever. The static reasons, the intermaxillary relationship, all do treatments with implants because now and where I'm based in Portugal, 25% of my clinical cases are retreatments. I'm retreating patients with implants already. But the old patients are not so challenging for me, but the new patients, patients with 30, 35, 40 years, these are very, very challenging for us. And I bring you some science to mix. And this is a very interesting paper from a colleague from Peru that gave us another different view in terms of categorizing our bone. Until now, we have the type 1, type 2, type 3, type 4 type of bone. And Rosas from Peru gave us a completely different idea with more two subtypes of bone. The type 4, the type 5, that is a regenerate bone, and also the type 6, that is a pathological bone. It's interesting when we compare our results to notice that if we have this kind of two different kind of bones, the results can be different. Of course, that is always a challenging for us to place our implants in this type of bone. I don't know why it's stopping again my sharing. Let me double check again. It's working now. Okay, several protocols, and this is the most important slide of my presentation. We must be careful when we do our preoperative evaluation. I'm quite extensive when I study my patients, not only with orthopantomography. The OPG is very important, but the CBCT or the CT scan is crucial for the edentulous patients. We cannot do a proper job without this examination. And of course, when we go to the market, we see that our 3D software, surgical guides, multifunctional guides, titanium guides, all these kind of helps that can allow us to have a better plan for our cases. The reverse planning, the DSD, the stereolithographic models, and of course, now the navigation. Today, I will focus in the surgical part, not only what we have available, but also other options that we can use, like a bone graft, or distraction osteogenesis, and the over-the-edge concepts that I will not talk now. I will talk about Olin-6, Olin-4, transsinus, transnasal, zygomatic, short and narrow implants, pterygoid, and superiosteal. We don't have time to go very deep. This is a webinar, but of course we will be open to questions and if you have the opportunity to go live in one of these dates, we can talk and share experiences. And the prosthetic part, that cannot be forgotten, because we now are in the digital world with photogrammetry, with softwares that allow us to do very nice and interesting prosthetic works, and also the intraoral scanners. Now, what I will bring today different, the implant that we are using. And all of us, we know that sometimes we are not able to reach a primer stability that allow us to do immediate loading. Of course, as a surgeons, as prosthodontists, we always say that the quality of the bone wasn't very good. And in the majority of these cases, it's true. But until now, we only do our evaluation according to the bone quantity of the patient and not with the bone quality of the patient. This new implant is integrated in the kit that will allow us to evaluate the bone quantity and the bone quality. As you can see here, there is a macro geometry that is very aggressive. This implant is for colleagues with experience in implantology. We do connections, the external connection and also the con-morse connection, as you can see here. And here we have 11.5 and also 16 internal angles. 11.5 more used in the past, now 16 degrees each time, more and more used in the new approaches. We also have these cervical microthreads that will increase the primary stability when we place our implants. And we know that sometimes is in the last moment that we are placing our implants that we will reach the primary stability that we want. And we are talking about 45 meters centimeter. And these new implants has two modalities, the double acid etching, double acid attack, as some of the colleagues say, and a new surface, the HA Nano. And what is interesting in this new surface is very hydrophilic, is a layer of hydroxyapatite that will increase the interaction between the implant surface and the autogenous bone that are available. More, because it's so hydrophilic, we will see when we place the implant, the blood coming from the apex of the implant to the body of the implant and also to the cervical area of the implant. And this super hydrophilia we can see easily in this image here. And it's something very interesting because we know when we place implants, from time to time, we almost don't see blood around the implant surface. And in difficult cases, like patients with osteoporosis, with diabetes, smokers, all the microvascularity around the implant is so necessary, is so important to keep the bone around the implant. And we should talk always in a middle term basis in terms of time. For us, we cannot have a short success. It's a long success that we try to reach. Now, what gives more primary stability to this implant is this inverted support with the double threads. As you can see here, these V threads are used to resist tensile forces to the lateral sockets. And we can use this implant in the extraction sockets, and also it was developed for immediate loading. Even in bone with very poor density, we can reach a very good primary stability. And we talk about 45, 40 newtons, even when we only have a little bit amount of bone in the apical area. The apical area is also flat, which means that we will not penetrate the maxillary sinus and we will not give some kind of forces to the alveolar nerve. And this is important, avoid alterations of sensibility of our patients. And of course, the components, the prosthetic components, we also have this need of biocompatibility and to achieve the best passivity in placement of our implants. The prosthetic components come in a pink anodized 14 reference, what tries to mimic the soft tissue of our patients. From static point of view is very interesting, and of course from the marketing point of view is also very interesting because it's new in the market. And this line allows us to do platform switching, what is very important to seal the cervical area of the implant, allowing the soft tissue and the keratinized mucosa to be around the implant neck, and also avoiding the micro gaps with the bone loss. And finally, the surgical kit. And I will take a little bit more here because it's very important to look to the image in the middle area, right area of the image. And as you can see there, for a 3.5 diameter implant, I can use 2 burrs, 3 burrs, or even 4 burrs. It depends if the bone is soft, if it's medium, or if it's hard. Now, we are changing the perspective of placing implants, not only considering the bone quantity, but also the bone quality. And the bone quality change from the anterior part of the maxilla or mandible when compared with the posterior part. And even in the same patient, we can have different bone densities. what means that our osteotomy protocol must be adapted to each implant. And we can do this with this kit and with this implant. It's very interesting because in the beginning it seems a little bit confused, but when we start to work with this system, it's the other way around. We cannot work and come back to the old days where we only do perforation of the bone. No, we must analyze the quality of each osteotomy. Now, moving to the clinical cases, not to be very boring for you, and I brought some concepts that you use. I like to place 6 implants, not only the maxilla or the mandible. Some concepts that we try to put in our clinical protocols. The primer stability, we try to achieve more than 35 Newton per centimeter. I try to avoid the super torques. Everything that is more than 50, I try to avoid. I come back with an implant, I pass a new burr, and after that, I try to insert my implant. 45 is the gold number for me. I try to avoid more than one tooth in extension and severe perfunctions. It's important when we treat total edentulous patients, consider not only the smile line, the transition area between our prosthesis and the natural mucosa of the patient, but also the lip support. That is one of the main complaints of the patient, the lip support. And of course, sometimes we need to tilt our implants. When we talk about maxilla, we have to palatinize our implants. Also important to know that we have different quantities of bones, and some areas we need a thinner implant also. And all these concepts work very, very well. In the old days, we do a maxillary sinus anterior wall window. Now we don't need it because the CBCTs are so accurate that we can go straight. And this is also a paper from 95, a clinical oral implant research, a historic paper from PI Brainmark when they compared the placement of 4 to 6 implants. And it's interesting to see that the survival rates for implants and prosthesis was almost the same in both groups at the end of follow-up period. But I know that they already changed some Olin 4 to Olin 6, and this could be an interesting conversation in another time. And I brought you one simple case that is a patient that came to us. It was a professor that has a student, and she lost a bridge, a dental bridge, in the second quadrant from central to canine, and it was the time to change and to lose the removal prosthesis. She wants a fixed option. And of course, like always, we always say to our patients, okay, let's go and study your case. We start by an OPG, standard OPG, as you can see here, and we always try to treat our patients in the full rehabilitation, not only the maxilla or the mandible according to the patient, but the full mouth rehabilitation is always our goal. And this is a typical maxilla where we can see in the anterior premaxilla some concavities from early tooth loss, some kind of bone resorption, as you can see there. In the posterior area, we didn't have so much bone available. Of course, we know that to extract this teeth is sometimes very tricky. Canines are long teeth with endodontic treatment. They don't have so much mobility. The molar has a periapical lesion, of course, also. And here it is, all the cuts, sagittal cuts to measure our bone availability and the 3D reconstruction. In the mandible, by curiosity, we can see that we have two missing teeth over there in the third quadrant. And we, as I told you before, we try always to do the full mouth rehabilitation. Now, here it is some of our concepts. We removed the bridge. It's important to do a mechanical curettage about all the alveolus. and to be a careful extraction of our teeth to maintain the most that we can the bone, and we only cut bone with piezo surgery device. The piezoelectric surgery is very important. We avoid bone necrosis with a cavitation effect. It's very, very important, and we can use the bone that we removed. When we talk about anterior maxilla, we try to place our implants a little bit palatinized. The easy way is to put our implants in the dental sockets, but as you know, the degree of resorption of the vestibular plate will be massive with time, and the implant will be exposed. It's important to use all the available bone. I like to have anterior support, intermediate support, and also posterior support. And here it is our implant. And as you can see here, double acid etch. And this type of implant will give you a very good primer stability. Distribution of our implants, multi-unit abutments, straight multi-unit abutments. I always try to place larger implants in the posterior maxilla when we compare to the anterior mandible and immediate loading. And here it is, the final aspect. And as the patient comes out of our clinic with a provisional bridge, here it is, one tooth cantilever, and here not normal. We don't do 14 teeth as provisional. We always do 12, but because we have occlusion in the posterior area, we try to give more comfort for the patient. And here is our control of post-op. And of course, I like OPGs, but I love CBCTs because here is the real result. What we achieve is very well demonstrated in the CBCTs. And here are our implant placements, maximizing the bone of the patient, the mandible, just for curiosity, try to rehabilitate the mandible, go faster. And after 4 months, we start the final rehabilitation. We're using the ExoPlan and ExoCAD, in this case, ExoCAD. We try to do, this was the bridge in CAD CAM, and it is the final aspect of our patient. It was a ceramic zirconia bridge, always a screw retained bridge because we like to do maintenance of our patients, and from every 6 months the patient come to the clinic. And final result with passive adjustment of our structure, and the EpiCat allow us to do this. Now let's go to do more cases and even more difficult. Well, now he only used 4 implants. I like the all-on-4 concept in the mandible, not so much in the maxilla, but in the mandible is very interesting because in the posterior mandible, sometimes we don't have another option and we need to do 2 straight implants in the area of lateral incisors, central incisors, and in the second premolar to tilted 45 degrees implants. That key, of course, they will be after that rehabilitate with angled multi-unit abutments that allow us to cover and to compensate this kind of angulations. It's very, very important if you have not so much experience to have a all-on-4 guide. I like to see the mental nerve because I see the concavity of the bone, but I also see the loop, the 6 millimeters anterior loop of the nerve. And this is a paper from Paulo Malo Bohanger from 2005, was the first paper about the all-on-4 concept. They evaluate 128 implants, and the cumulative 1 year survival rate was about 97.6, what was very impressive at the time. I brought you a simple and also at the same time classical case for the patient with no occlusion at all. We can see that there was one tooth occluding, a patient that has no teeth for a long time with removable prosthesis, and like all the patients, the worst prosthesis is always the lower one because the upper one they can survive. There is the palate that gives some support, some mucosa to give support, and this is the classical case with anterior area in the mental area and no bone in the posterior mandible. And the Olin 4 is the technique that we use on this kind of patients. Good density, but we know that sometimes in the bone there is a part that is very, very thin, and we have to cut it to create a bone platform to place our implants. And here it is. We do full thickness flap. We expose well the bone, anterior part and posterior part. We create the bone platform again with piezo device and all-on-4 guide to control our implants. And here it is, the EpiCut, allowing us to have a very good primer stability. And the image at the left up image is very interesting because we can see the angulation of the posterior implant, and we can visualize also the nerve. It's very important to identify the nerve. I like to identify the nerves to place our implants. I always like to place my anterior implants first because they give me a perspective about the angulation that I can use. And as you can see here, the compensation with angled multi-unit abutments, 30 degrees, in this case 4 millimeters, and I stitch, goes to the lab, and 2 hours after, here we have the professionals, a reinforced wire in all our professionals, and one tooth cantilever. Again, a professional prosthesis with 12 teeth. And this is the traditional image about the Nolan 4. Important, as I told you before, the CBCT with the concept. Okay? The EpiCut brings us more previsibility to these kind of cases. Final rehabilitation with a titanium bar and acrylic teeth to the patients, the same procedure. Passive adjustment is crucial in these cases. And here it is, the acrylic. Of course, I know that the patient, for economical reasons, didn't done the upper jaw, maybe in the future, but for now, we have a good and interesting case. Now, let's move on for the transsinus concept. This concept is very interesting because the concept allows us to achieve primer stability when we place the implant in the apical area, goes to the canine apical area. Of course, some of you can say, but we don't have so much bone. It's true. And according to the morphology of the maxillary sinus, we can angle more or less, or even we can even do a bone graft in the same time of the implant placement. The key point is that implant must have some kind of stability in the cervical area and also in the apical area. It's a very interesting paper from Dan Watzlaw group in the States, and where the transsinus approach can be used as an alternative to the zygomatic implant in very severe edentulous maxillas. And now we start to speak about transnasal approach. Very interesting how we are maximizing the anatomical areas available. And this is the work from Vanderlyn. And Vanderlyn is saying that we try to expose the nasal cavity and try to place our implant in this kind of anatomic areas. They published 12 cases, not much, and the follow-up is not so long, but anyway, you can see here the concept is very interesting, combined with zygomatic implants that allow to place implants in the middle third of the face, and these transnasal implants must be very, very criterious in terms of bone direction. And SIN has already one implant um, developed to this kind of clinical situations. Now, an area that is already well studied and well used is the tuberosity and pterygoid area. Until now, it wasn't so much used. And this triangle that you can see here in the posterior area that involves the second molar, third molar, was not so used. And for me, I couldn't achieve so much good primary stability. I was placing the implants over there, but I was placing implants with 10 newtons, and I was not so confident until I started to use the EpiCat. And this paper from Dietrich described very well what we want and where we want to place our implants. As you can see here, the anatomy of pterygoid region with the maxillary tuberosity in the anterior area, the middle pyramidal process of the palatal bone with the pterygoid notch, and also the pterygoid process of the sphenoid. And if you reach this bone, is with very good quality and will allow us to reach a very good primary stability. Now, this is a typical case. That's a patient that no one wants. Why? Because she was a teacher, she was retired, and she was a PhD in Dr. Google, and she knew everything about implants. She came to my clinic and she asked me 4 questions. First question, how many implants you will do me? A Nolan 4 or Nolan 6? Good. Second question, do you do me immediate loading? Okay. Third question, which kind of titanium is your implants? And fourth question, how many years this rehabilitation will last? Can you imagine? After these 4 questions, you will say, I'm closed for holidays. I'm not operating for the next 6 months, and go home. But no, I answered the lady. I cannot answer you without a CBCT. We need a CBCT. It's not a question of number of implants, because I don't charge by implant, I charge by solutions. This is important. 4 or 6, we will see. Second question, all our implants are CE certified and all have a good type 4 titanium, okay? Now, immediate loading, we will see, because according to your not only bone quantity, but bone quality also. And fourth question, how many years the implant will last is a very tricky question. Why? Because I only do half of the treatment. And she was very surprised. You only do half of the treatment? Yes, it's true. The maintenance of our treatment, the other 50% is up to you, because there is not auto cleaning in any implant rehabilitation. And she, okay, I think I will do it with you. Because when we put only facilities to our patients, when we say that everything is easy, we are in trouble. And we must be very realistic. And as you can see here, the facial musculature of this patient was already changed, and there was no occlusion. Well, I was not operating only the patient. She brought all the family with her, the daughter, the son, and all of them had some questions regarding the mother, normal nowadays. And as you can see here, the CBCT, you will see that the density of this bone wasn't quite so good. The quality was not so good. And I was trying in the old days, maybe I will do here Nolan 4. Now I work in a different way. I put this case because I combine 2 clinical techniques that I talked before. First, the pterygoid area, you can see here a triangle that we can maximize in the posterior maxilla. And also not the transnasal, because the implant that I use here, it was an apicat, not the implant developed for the transnasal, but we were on that path. We are trying to reach that anatomical area also. Now, here it is, the bone available, and the mandible was unbelievable better. Now, I will show you, of course, better with some anatomic restrictions, because the nerve was not so, it was a little bit superficial, of course. But it is interesting how the cibicity can reach as a point as when you compare the maxilla density, bone density with the mandible, it seems a completely different patient. The bone density in the mandible was so nice, so good, and in the maxilla, it was so soft. Okay, same patient, but with anatomy and bone quality completely different. As I told you before, this implant line allows us not only to evaluate the bone quantity, but also the bone quality. And this is so important. We start by the maxilla. We extract the teeth. We create our bone platform. Again, we try to place our anterior implants in the palatine position. We angle the intermediate ones. And as you can see there, in the final area, we try to place our tuberosity pterygoid implants, maximizing all the bone available to these patients. And this is, for me, the main concept I will want to pass to you. Now, mandible, a classical one for two straight implants in the premandible, in the symphysis area, and two angulated implants in the posterior mandible, compensated with angulated multi-unit abutments. Now, reach to have primer stability and immediate loading. Let's go to the images of the patient. Let's go to the OPG and see how we are maximizing our bone. Now, in the old days, maybe I will do only an all-on-4, and I was quite happy with that. But now I try to also incorporate the pterygoid and tuberosity bone with implants. And when we go cut by cut, as you can see here, the cross arch stability very well defined in the 6 implants. And when we go here, see that we are reaching the nasal area. It was the first cases that we are trying to reach the nasal area, and here is well seen. Okay, mandible, a classic all-on-4. And here it is. Rehabilitation, final rehabilitation of the patient. Again, 2 structures, CAD/CAM, exocad technology with titanium bars and acrylic in this case. It's always important that the passive adjustment of our structures. We are very careful with this. The maintenance of our patients is also very important. And finally, can the situation be worse? Yes, it can. We could have cases with more resorbed maxillas, and we need to use the zygoma bone to place our implants. And here you can see the evolution of the zygoma concept. I have an experience of 25 years with zygomatic implants. Well, of course, when I started, they call me a lot of bad names, but now the concept is more and more accepted. I have almost 1,700 cases, what means that I operate a lot. Even today, I done zygomas. And the major indications are severe unilateral and bilateral maxillary resorption, the cleft palate, bone graft dehiscence, contraindications for bone graft, and facial mutilations like annexillectomies, tumor resection, trauma, congenital defects. And we should say also clearly that as we go major in this surgery, the the complications and the risks are also higher and higher. This is one of my last publications in the Journal of Clinical Medicine. It was last month that we done an evaluation of 100 implants with more than 10 years of follow-up, not one, not two, 10 years of follow-up. And it's interesting to see that the resorption at the level of the zygoma, 10 years after the placement of the zygomatic implants, revealed there is no significant losses between the initial and final controls. What means that the degree of resorption, because the quality of the zygoma bone is so good, when we're talking about type 2, allow us to say clearly this option is very, very interesting. And combine in different protocols. The first one was 4 anterior standard implants with 2 zygomas, 3, 2 with 2 zygomas. Now we are incorporating also the quadrilex with 4 zygomas, and now the pterygoid can be also combined with zygomas. The posterior anchorage of our zygomatic implant can be moved according to our treatment plan. Now, how we place our zygoma, we can choose the position of zygoma. Yes, it's true, we can. We follow the Zaga classification that the zygomatic anatomy guided for the zygoma. According to the concavity of the posterior sinus, maxillary sinus, we will place the implant in the interior intrasinus position to more posterior intrasinus position. It's important to see that we go according to the anatomy of our patients. And I will show one clinical case with the new zygomatic implant, just for you to have an idea. These patients, of course, seems very sometimes older than what really they are. This is a kind of case. And it's strange. I told you that 25% of my clinical cases are retreatments. And I'm very, very detailed when my treatment plans. And this was a patient that told me, please change me my upper and lower jaw. And okay, she came from the south of Portugal. South of Portugal is Algarve. And when you are from UK, you know that Algarve has the best weather, the best beaches in our country. And she came to Bordeaux, with my hometown. I live in the land of the wine, and she done like 700 kilometers to see me. And she told, please retreat the upper jaw, treat the upper jaw and retreat the lower jaw. And as you can see here, the upper jaw didn't give so much margin to place my implants. Zygomas, there's no question about the zygomas, and I find three anatomic areas to place my implants. The canine area to place 2 implants, and another extra anatomic area that I would like to share with you. We will see. Now, the CBCT for the zygomas must be different because we go to the supraorbital level, from the alveolar bone to the supraorbital level, and see the quantity of the bone that we have available to place our zygoma implants. Very interesting, because sometimes we cannot place 2 zygomas, but 1 zygoma for sure is guaranteed. And very good density of the bone and the mandible also. And see, the way I think is I couldn't retreat the mandible, only extracting teeth and placing 2 implants. I was not quite happy with these implants that one colleague had placed like 3 years ago. I didn't charge more the patient, but I said, I will do a new mandible if you don't mind. And she told me, okay, I trust on you. Okay, this is the mandible for you to see the final results. The angulation of the implants were not so good. The periapical lesions, I didn't like it. The bone need to do a new osteotomy. Now, this new implant from SIN is very interesting because the protocol starts by the round burr that we put in the a point, as we say, that is the entrance of our implant, and we have a first bar to do all the path of our implant. Now, in the zygoma implants from SIN, the new zygomas, we are also considering the same both concepts in the apical line. Okay, quantity and quality of the bone. The density of the bone is very important. This burr, this yellow one, cuts only the lateral part, creates a slot for our implant, avoiding the intrasinus entrance. And as you can see here, we are placing our implant that is a con-Morse connection, also combined with the zygoma. The body of the implant has no threats. The microbiology is more favorable. There is no microorganisms contamination, what is very, very interesting. And the quantity of implant that is inside the zygoma is quite remarkable. More the body of the zygoma will close the communication to the sinus. It's like the patient don't feel it. And we did go inside the sinus to avoid the sinusitis. Now, see the maxilla and distribution. Now, in this picture, you will see that I place an implant in between the two, the interincisive area. And I'm using often this anatomical area to place implants. Now, mandible, just for question of curiosity, as you can see here, part of the implants were already exposed in 3 years, and I think that was the decalage between the anterior bone and the posterior bone. I create a new bone platform. I place 6 apical implants, straight implants, and my result was this. Now, column 6 in the mandible, no conversation, so we are used to use this, okay, no worries. Maxilla, pre-maxilla, not only the canine position that I placed the 2 implants, but the intra-incisive area. Sometimes I clean the intra-incisive foramen, the nasopalatine nerve, and I can place the implant inside the nerve canal. And the zygoma implants, as you can see here. And here it is, the bone the distribution of the implants with the cross-arch stabilization. And this image is a very nice one because we will see the distribution of our implants now, and the zygoma, maximizing the zygoma with our implants. As you can see here, 3D reconstruction of the bone and the mandible distribution with the epithets in the mandible. Now, we have a story of this dental patient. So we start to publish in 2004, as you can imagine, plenty of papers in this area because I told part of my life is to publish. With conclusions, most complications in implantology are closely related with the planning details. And we know that we must not only do the cases, but preventing complications. Surgical and prosthetic complications is essential for nowadays for our work. And of course, we must have the patient collaboration and responsibility. They have responsibility in this treatment. We should have a team spirit to work hard, and the materials are very, very important. The implant line that we work with makes the difference, and this particular area makes a huge difference. The Olm 6, the Olm 4, the transinus, the pterygoid, the zygoma concepts, all these concepts are like weapons. When we use in our favor, they will be very, very interesting. And of course, final challenge is always the zygoma implants that we can and you should train to sort some more difficult cases. And my contacts, any doubt that you like to do, if not participate in this chat, I will be completely available to to talk with you. Okay, sorry, my time. Sharing. I'm not sharing anymore my screen. Sorry, Rod, it's up to you now.
Whoa, it was amazing. Thank you very much for the presentation, Dr. Fernando. And I would like to invite all the people to be free to ask anything you want to Dr. Fernando. If you have any doubt about the presentation or about any topic presented here, so please feel free. No questions?
Let's have a
Oh,
question. Is it clear?
We can hear you. Yeah.
Yeah. For the case on the all-on-4, why was the angled multi-unit abutment were a little bit higher than the straight one in the anterior? It's just a small question.
No,
Thank you
but
very
it's a
much.
very good question. Thank you very much. Normally, we do two sets of multi-units. The first set was during the surgery, and of course, we try to because we have the gingiva sometimes with edema. I place the multi-unit abutments that I think are the most suitable for that case. But after 4 months of osseointegration and before the final rehabilitation, we will do a new setup of multi-units. And sometimes they change it. And the rehabilitation in our clinic is done by my wife, and she's very meticulous. She's very detailed. And you were very good observer, but she will change it to create the same level in terms of multi-units. Not only the straight ones, but the angled ones. They should be at the same level. Okay, it was my mistake, not her mistake. She will compensate and she will place them at the same level. Thank you for the question.
Yeah, thank you very much. It was just a small observation thing. I don't mean to have any problems here, but yeah, thank you very much.
Pleasure.
oh, excellent, excellent. Great, great question. So, anyone have any other question, any other situation you'd like to talk about, to ask about, any specific procedure across the topics we have talked?
Hello, hi. A very great, nice
Hey,
presentation. Thank you. I have a question, so there will be some questions. So, why do you try to avoid higher torque values than 45 Newton centimeters?
Normally, because in the long-term basis, I have more resorption compared with the 45. And when I'm talking about super torques, I'm talking about 80s and something like that. I don't have good results with this kind of torques. I saw some publications, I saw some colleagues that tried to this kind of super torques, but I try to avoid them in my clinical basis and comparing my results with lower torques. I have less bone resorption, and my limit, I try to keep it in the 45, maximum 50.
Thank you very much for your answer.
Yeah.
excellent, great, great, great question. Dr. Fernando, there is a question in the chat. Can
Okay.
you read the chat?
Yes, I will. Super symbol for atrophic maxilla. Okay. Thank you for the question. Also, it's a very interesting option, the superiostal implant in some cases. For the maxilla, for the atrophic maxilla, I don't use them so much because I have all these weapons that I show you today. But for mandible or even for maxillas to avoid massive bone reconstructions. And when we know that the patient is afraid of bone reconstructions or have some kind of bone complications, I think the supraperiosteal implant is a valid option. But it wasn't my topic for today. Sorry.
Excellent, excellent. Great question. Great. So, guys, feel free if you have any other question. It's your best time to ask Dr. Fernando. Also, I would like to let you know, you see in our social media as well, Dr. Fernando will be here in London with us on the 30th of April. So we'll have a face-to-face event with him in London. So, and we'll be very happy to have you guys with us as well. So talk to us. We'll be very happy to help you to be with us. Okay? Very nice.
It was a pleasure. Good afternoon to all of you, and we keep in contact. Any doubts, any thoughts, any share experience, I will be delighted to answer and to learn with all of you. And of course, with all of us, that all of you that can be live with us will be fantastic. And thank Rod and Titania Medical for this opportunity to share our work and to be with our colleagues from the UK.
Oh,
And I have another question.
Okay.
So, as I saw, you are using different connections. So, do you see any difference between conical connection and outer hex on the same implants?
Interesting, very interesting questions. In this using the same implant line, I'm more comfortable using the Conmorse connection in the long-term basis, and from the biomechanical point of view, in my hands they work better than the external connection. I have better experience. For ages, I was an external connection guy from the 90s, and I changed for the Conmorse connection, and I'm quite happy. By studies, by my work with SIN, I tried to use both to compare results. In my hands, I like the most the Conmorse connection.
Thank you very much.
excellent, excellent. So, guys, if you have any other question, okay, fantastic. We have some messages here in the chat. So, Nabil Kahi, great talk. Greetings from the USA. Thank you. So, Sergio Rasila, greetings from Romania.
Oh,
Uh,
we live in Romania, yeah.
Osumi Iqbal, I'm so sorry if I'm not pronouncing correctly. Thank you, great presentation. Omar Karatun, thank you for the great presentation. So,
Oh,
also
Masuni is from Bangladesh. Okay.
greetings from Bangladesh. Wonderful, excellent. So great questions, great group we have here today. So I'm really thankful for all of you guys. So it was a pleasure to serve you, to be here with you, to see all the sharing information in this opportunity. And thank you very much, Dr. Fernando. We are excited waiting. We can't wait for you here in the UK. So, guys, thank you very much as well. Have a great night, everyone. So, see you in the next time.
See you next time, Rob. Thank you very much. So, bye-bye, Michelle. Bye-bye, Rob. Thank you.
Thank you,
Bye-bye.
Doctor.
Bye-bye.
See you.
Bye-bye.
Thank you, everyone.